Hello, good evening, everyone. Welcome back to my IVF and the European Fertility Society. We are back after a short break during Christmas and New Year's Eve. So anyone joining us today, I would like to let you know that this is our first event this year, and there are plenty of topics and plenty of guests that we've already invited. So it's going to be an interesting session today, I'm sure. But I want to ensure you that there are plenty of topics that we have prepared already for you, and we are just starting. So thank you everyone for joining us today. And as you can see, Dr. Kristýna Frühaufová is with us today, and she's the head physician at the GYNEM Clinic located in Prague. So welcome back, Dr. Kristýna, lovely to have you. I hope you are ready to educate us a little bit more. You've done some webinars with us, so you know how it all works. And today, we will focus on infertility and fibroids. And of course, we will start with Dr. Kristýna's presentation so she can walk us through all the aspects that you should know. But afterwards, there will be time for your questions. So as always, please put those in the chat. Dr. Kristýna will be happy to answer them for you, I'm sure. Thank you so much for joining us this evening. I hope you had a good day and are ready to simply provide us with your experience, some information on this particular topic. I'm really looking forward to it.
Okay, thanks a lot. Thank you for the invitation and for the opportunity to share my expertise. Before I started the IVF, I worked in the laparoscopy, the minimally invasive unit, for a long time. So this is like really close to my heart, the fibroid topic. So yeah. I think that we can go ahead with the presentation, and then I'll be happy to answer the questions that you have.
Brilliant. Thank you so much indeed. That's good to hear, of course. And remember, we are here for you. So if there's anything you would like to ask, just type this in the chat and we will take care of those questions right after the presentation. Remember, everything is recorded, so you will have a chance to rewatch this. It will be published on our YouTube channel and our website, myivfenses.com as well. And also remember, this is all anonymous. So anything that's on your mind, you can type this in the chat. It's all anonymous. And I think we can go ahead with the presentation on our topic. And afterwards, we will go for your questions. Thank you so much, Kristýna, and let's go for it.
Okay, so thanks again. And I would like to welcome everyone. And I'm going to start with a brief introduction to walk you through what we know about the uterine fibroids. So basically, what are the uterine fibroids? They are the smooth muscle benign tumors. As you can see, it's quite wide, and it's age and ethnicity dependent. So we see more fibroids at younger age, especially in Afro-American or Asian women. On the other hand, Europeans tend to have less fibroids than the other ethnicities. The growth of the fibroids is hormonally dependent, so they tend to diminish after the menopause. It is said in the literature that almost half of the patients are asymptomatic, so they don't know about the fact that they do have fibroid located on their uterus. However, if the symptoms are there, the most common ones are heavy bleeding during the menstruation period, pelvic pain, or pressure complaints. The symptoms basically depend on the location of the fibroids. So in the ways to describe the location, there are basically 3 different types of fibroids, and the ones that are located within the uterine cavity or disturb the lining of the uterine cavity are called the submucosal ones. Those are the ones that we may see when we enter the uterine cavity with the hysteroscope. Then the fibroids located within the wall of the uterus are called the intramural one. They also may present themselves inside the cavity or outside the uterus, depending on their size. And the fibroids that are located outside or let's say within the capsule of the uterus are called the subserous one. There is a special type that's called pedunculated that is sort of connected to the uterine wall with a pedicle and a feeding vessel. So What is the connection between fibroids and infertility? We still don't know. We know, on the other hand, that fibroids present higher risk for pregnancy, especially in the early pregnancy. When you have a fibroid that is located within the uterine cavity, then there is a higher risk of early pregnancy loss. This risk is about 1/3 higher than when you don't have any fibroids at all. Also, the pregnancy-related complications may occur later on during the pregnancy. The most common ones are the risk of preterm labor, especially in women with large fibroids, the fetal growth restriction, which means that the baby is not fed well within the uterus and is not growing enough, or there might be some complications during the labor. There might be higher blood loss in women with large uterus. There might be an issue with heavy bleeding after the birth. So most likely you're going to ask what is the connection, or what actually is the reason why the fibroids may interfere with the fertility. So there are several factors. We may start from the conception itself, because when you have large fibroid that is a cause of severe pelvic pain, then having the intercourse might be almost impossible. Another factor is that the location of the fibroid may actually interfere with the transport of the sperm, the oocyte, or might interfere with the embryo implantation itself. So it might play a role or be a mechanical factor of infertility. Also, when you have the fibroids, there might be changes in the microbiome, altering the immune response. So it may have a negative impact on the implantation of the embryo. And also the fibroids may disturb the blood flow within the uterine cavity, which may alter the way that the placenta is being formed. That may lead to either miscarriage or preterm delivery when there is insufficient placentation. How can we find out that the woman has a fibroid? So the first method of choice is to do the ultrasound. You may describe even small fibroids using transvaginal ultrasounds. The bigger fibroids are usually discovered using the combination of transvaginal and transabdominal ultrasound. When there's a doubt about the biological origin, we may use the MRI. That will provide us more insight on the tissue itself. Or we can do the direct diagnosis by hysteroscopy or laparoscopy to look inside either the womb or the abdomen. The first method of choice still is a surgical treatment if we need to treat the fibroids. There are some advances in the pharmacological treatment as well, and there are some options such as, for example, the uterine artery embolization that I will mention later on, but those are not designed like the first method of choice for women desiring pregnancy. So if we want to talk about the surgical treatment, the first option is the hysteroscopy that is suitable for patients with myomas located inside the uterine cavity. Hysteroscopy is quite easy procedure. The resection of the myoma takes about 10 to 20 minutes. The small fibroids may be removed during one setting. If the fibroid is larger or is located more within the wall of the uterus, there might be 2 or 3 hysteroscopies consecutive needed. But most of the fibroids that are located within the uterine cavity may be treated by hysteroscopy. For fibroids that are within the uterine wall, we tend to choose the laparoscopic or robotic or laparotomic procedure, depending on the size, on the expertise of the surgeon. We tend to treat larger fibroids, usually fibroids above 4-5 centimeters in diameter. The fibroids that present themselves with some symptoms. So if the patient is suffering from heavy menstrual bleeding, has, for example, pelvic pain or things like that, then we are more likely to operate. Patients that have had miscarriages in the past, the only issue with this approach is that there is a waiting time in between the surgery and the pregnancy. Usually this is a period of 6 months that is needed in order to allow the healing of the scar on the uterus. The pharmacological treatment has been used mostly for patients awaiting surgery. At the moment, there is a new peroral treatment that's called releukolix. It's the GnRH antagonist in tablets that may be used in, for example, for 3 to 6, 9 months period. And this treatment brings symptomatic relief, and it seems to be helping in reduction of the size of the uterus. But still, this is more for patients that are waiting for the surgery. It won't heal or won't help to diminish the fibroids totally. But it is safe in patients planning pregnancy, but still we need large data because it's quite a new drug. As I mentioned, there are some other options, such as the uterine artery embolization or high-intensity focus ultrasound, but those methods, they don't lead to reduction of the volume of the fiber that would be sufficient, and also there is a high risk of uterine necrosis and rupture later on during pregnancy. So those methods are not recommended for patients who want to get pregnant. But if the patient is not considering pregnancy at that given moment, she might have some symptomatic relief when those methods are used. So in general, uterine fibroids, especially the ones that disturb the uterine cavity, are associated with pregnancy-related complications. If we see intracavitary or submucous fibroids, they should be removed prior to IVF. The fiber is located within the uterine wall, then we discuss the options with the patients depending on the size, location, or the symptoms. Still, the first choice for treatment is the surgical one. And if we are removing the fibroids using laparoscopy, laparotomy, or robotic surgery, we have to inform the patients that she has to wait for at least 6 months in order to heal the scar on the uterus and to allow safe pregnancy. So that's basically all, just to wrap it up, and I'll be happy to answer your questions. So thanks for now. So we can go to the questions.
Thank you so much indeed for walking us through all the aspects, all the treatment options as well when it comes to fibroids. And now we will have your questions. So if you have any, go ahead, type those in. Before we start, I do have some questions that will be like a summary of what you just described, just so we can make it clear for anyone. And the first question that I have for you, so this is the short one: can fibroids stop implantation?
Yes, as I mentioned, depending on the location of the fibroid, the fibroids may be a mechanical factor that may sort of interfere with the implantation of the embryo. So that's one thing. Also, by changing the microbiome, the immunological situation within the womb, they may also play a role. So not only mechanically, but also immunologically wise.
Okay. I will ask you the next question, and we will wait for your questions in the meantime. So what kind of fibroids affect fertility? You also mentioned this, but if you can summarize.
Yes, it's especially the fibers that disturb the uterine cavity, so the ones that we can call the submucous, or the intramural, especially larger intramural fibroids that have some submucous component by themselves. So they sort of tend to grow inside the uterine cavity.
Crystal clear again. One more question. So how common are fibroids in women undergoing IVF?
This is hard to say because since we're located in Prague, we do have half of the patients coming from abroad. So I see that I can actually tell the ethnicity of the patients just by looking in the ultrasound without looking at the name. So I would say that more than half of patients that have the Afro-American origin, they do have the uterine fibroids, and they tend to unfortunately have the large one and multiple fibroids. That might be an issue even for the surgery, because when you have multiple fibroids, you have to maintain some healthy uterus, so you have to make the choice which is the largest, and let's say the fibroid might pose the biggest issue, then it has to be removed, but you still need to leave the small behinds. So in the European ethnicity, then I would say it's around 20% of patients, but it's also age dependent. So when you're in your 20s, you're most likely not to have any fibroids, unless we do see families. There's most likely some genetic connection, because when we have the history of the mother having fibroids, then their daughters are most likely to be affected by uterine fibroids at a younger age. But other than that, we see smaller ones that are not clinically significant.
Of course. Brilliant. Thank you so much for the clarification here. It's an interesting topic indeed as well to discuss. And now we will go for your questions. There are some questions ready right here. So let me go for the first one. From AD, for fibroids treatment, have you heard? I will show you because I'm not familiar with that. HIFU Sonata treatment. Is this treatment safe for those trying to conceive?
Yes, that's basically the HIFU is the high intensity focus ultrasound that I mentioned in the presentation. Generally, this is not the method of choice for women desiring pregnancy. The reason being not large reduction of the volume of the fibroid. There are lots of studies that describe the reduction of the volume of the uterus, but not actually the much significant reduction of the size of the fibroid itself, because it's a different thing if you describe the whole uterus or if you just describe the fibroid. So the clinical data hasn't been too promising on this method, and since you may cause the necrosis of the fibroid, that you create a tissue that might be insufficient during pregnancy, you do have a risk of uterine rupture. So I wouldn't go for this method as the first choice in women planning pregnancy, just to be on the safe side.
Makes sense, of course. Again, thank you. How about if you are over the age of 40, could you do a transfer earlier than 6 months, which you mentioned?
No. Well, this is like Europe is a bit different from the US. I mean, the surgeon from the US say that anything that doesn't heal within 6 weeks won't heal at all. But the thing is that we need to make sure that the scar that we create on the uterus will sustain the pregnancy. After the fibroid surgery, there's around 0.5 to 1% risk of uterine rupture, especially when the woman is in labor, not during the pregnancy where the uterus is growing steadily and slowly, so that the risk is not that high. But when there are contractions, the risk goes up, basically. So this is just to make sure that the uterus was healed properly. There shouldn't be any hematoma within the scar. So the 6 months is usually considered to be like the minimum.
Okay, thank you for the clarification here. More questions are coming in. Thank you so much for those. And does fibroid patient can take Clomid in an IVF process?
Yes, you can. We even stimulate with any kind of medication, again, taking into account the age, what is the prognosis, what will be the possible outcome of the stimulation. Of course, we won't stimulate if we see, for example, that there's a diminishing ovarian reserve. So we know that any hormonal treatment may actually induce the growth of the fibroids, but we do have patients undergoing IVF with fibroids with any kind of medication.
Okay, thank you. Next question is, so you mentioned the types of fibroid that affect fertility. However, my gynecologist told me mine won't affect fertility. Is that also an option?
Might be a case. I mean, if especially the ones that are sort of sitting on the uterus, they might be quite large. I've seen patients with 7-8 centimeters fibroids that are just outside. Depends on the location. Most likely it will be an issue during the labor. So, but other than that, there are lots of fibroids that we just watch and wait.
Of course, those are the things that you need to definitely check, right? But it's also not necessary that you actually need to remove them.
You can just follow up if the growth is not really fast, then you can just check it.
I'm sorry, there is a follow-up. Mine, the same patient, so mine is not inside, and it's 5 centimeters in size.
Well, as I said, 5 centimeters is usually like, let's say, the borderline between this. I mean, depending on the symptoms, if the patient has had any miscarriages, etc., etc. Also, the age of the patient, because it's the age factor, the healing process that we have to take into account. I mean, if the patient is 42, then most likely we would just go ahead with, let's say, the IVF treatment first, and then yeah, there are lots of factors that this is really hard to say.
So you just need more details, obviously, just to make a statement here for sure. All right, so thank you so much. If there's anything else you wish to add, you know what to do. Now I will show you a question, a bit of a longer question. That's why I need you to see it. I was diagnosed recently with 2 small fibroids, 1 and 2 centimeters, absolutely surprisingly, with adenomyosis in a lower stage. I had MRI. For me, this is an absolutely shocking diagnosis. We have had 17 embryo transfers and only 1 implantation failed in missed abortion. 10 different doctors made ultrasounds in the last years. Nobody has seen this. By what is this affected? Maybe by the treatments with medications, by stimulation. What can I do before we are doing the next transfer? Anything you can advise here?
Well, just my guess, because I haven't seen the ultrasounds, but most likely the fibers are not the reason for the implantation failure, unless they are located within the uterine cavity. But I don't think this is an issue. Most likely it's the adenomyosis. That might be a problem, because the adenomyosis basically is a different. The adenomyosis might mimic the uterine fibroids, may look like fibroids, especially when you have like very well-defined lesions of adenomyosis within the uterine wall. It might look like a fibroid, but it has a different origin. It's more closer genetically to endometriosis. We see different genetic mutations in fibroids and adenomyosis, so it's a completely different thing. In patients with adenomyosis, we see failures, and we see that there is high risk of miscarriage. And there are several reasons for that, starting from immunology, then altered vascularization, insufficient placental formation, and things like that. Adenomyosis can be treated hormonally rather than surgically. So we tend to then regulate the patients prior the frozen embryos transfers. So in adenomyosis, there is a place for hormonal treatment rather than doing the surgery.
Okay. Hope that helps. If there's anything else you wish to add, you again know what to do. All right. Does having fibroids have an effect in the percentage of success of IVF?
Again, no data to say whether we know that the chances are a bit lower, but since the fibroids, it's very heterogeneous group of patients because of the location of the size, etc. So, and especially when you tend to have larger fibroids in older women, that's also the age factor that we have to take into consideration. So, most likely, it does affect the success, but then we would have to go by the location, by the sizes to, let's say, divide it into subcategories to
Yeah,
have the
to
clear
make
answer
it
to
clear,
that.
right?
Yes.
It's impossible to do it otherwise. Yeah. All right, thank you. More questions are coming in. So, can you have a natural delivery after two myomectomies?
Yes, you can, but depending on where was the fibroid located, what kind of suture you have, if in my experience, we always in patients that we had to go deep inside the myometrium or where we had to open up the uterine cavity during laparoscopy, those were the patients that were obliged to deliver with the C-section, because then the more layers of the suturing you have to put on the uterus, the higher the risk of the rupture. So if you, for example, have only superficial myomas, or if you had myomas removed by hysteroscopy, there is no big deal to have a vaginal delivery. But this should be defined by the surgeon who did the operation. They should inform you about what way, how to deliver.
Okay. Marie, I do hope that was again useful for you. There are like one question, I think. So if there's more questions, you know what to do. Go ahead, type this in. So the question is, are the IVF protocols the same as with non-fibroid cases?
Yes, pretty much the same. Just again, we have to keep in mind that we may induce the growth of the fibroid. So that's basically it. But since there is no, let's say, no hormone treatment, and it's, even in the natural cycle, you're producing estrogens, then still there isn't much to do to change, to alter in the IVF protocols.
Okay. Again, crystal clear. Thank you so much. One more question we did receive in the meantime. This possibly will be our final question. So again, if you have any more, you know what to do. Go ahead, type those questions in. So AD would like to ask you, is it possible for fibroids to die on their own and then come back, right?
Yes, it is. We do see it sometimes during pregnancy that since the major blood supply goes to the fetus, then the fibroid may actually die or so shrink during pregnancy. We do see it in small ones that they sort of sometimes they even form like a small scar. The expulsion, which means that the fibroid will come out, is quite rare. And I've seen a few cases in patients that had the fibroids located within the uterine cavity. But as I said, it's really, really rare that.
You need to be aware of that, yeah?
Yeah.
And this is something that you definitely need to monitor all the time.
Exactly, exactly. And when there's a necrosis of the fibroid, which is the process of, let's say, the tissue death, this is really painful. So that's something that might present with really severe pelvic pain and most likely will lead to the need of hospital stay. So that's
okay. Thank you so much. This is important to add that. All right. Any recommendation for vaginal probiotics for the endometrial microbiome? Bit of topic.
Well, each country has different products, so this is something that I cannot say. Usually, the Lactobacillus rhamnosus is recommended. That's like the major lactobacillus that should be located within the uterine cavity, if you wish. But this is really hard to tell what kind of exactly by name,
Yeah.
what kind of product, because the brand names are different on each market. So yeah.
Exactly. Remember that it's impossible sometimes to provide you with the direct kind of medication that is best,
Yeah.
right? Because of those differences. But I do believe it was again helpful, of course. Okay, one more question from Gabriela here in the meantime. Submucosis, fibroid. I think that can submucose fibroids be a problem. 2 centimeters. Can
Yes,
it be
that's
an issue with the implantation? Yeah.
well, 2 centimeters is quite large. So if it's really, if it's not the intramural width, even intramural that would have a small portion inside the uterine cavity might be an issue of this size, but this would definitely need to be treated. Depending, we usually divide the treatment. We decide whether to go for hysteroscopy or laparoscopy based on the maximum volume of the fibroid. If more than 50% are located within the uterine cavity, then we go for the hysteroscopy. If it's less than 50%, then it's treated by laparoscopy.
Gabriela, let us know if that answers your question. I do believe so, but of course, let us know. And in the meantime, I'm just waiting to see if there are any other questions. But in the meantime, remember that if you wish to get some more information and more, let's say, personal information as well, because of course, remember that any doctor will need all the medical history in order to properly answer. Remember, you can always get in touch with GYNEM Clinic and the team, and I'm sure they will be more than happy to help you out. And I see that there are some thank yous coming up your way, Dr. Kristýna, as you can see. Thank you both very much. Thanks. And of course, it was an interesting very informative, and there was also a comment about the presentation. Brilliant presentation, excellent presentation. Thank you everyone for this, and of course remember that we will be back, but before we finish for today, any final words, Dr. Kristýna, you wish to share?
Okay, I would like to thank everyone for this session, because I think that you had some interesting questions. The fibroids are really huge topic, and it's really difficult to cover within half an hour that we had on this. I could talk for more, but you don't have any questions. So basically, the treatment of the uterine fibroids depends on where they're located, on the medical history of the patients. So we really have to be more personalized, and there's no, let's say, silver bullet, that there's no treatment that would suit all the patients, and we have to judge it case by case.
Definitely personal treatment is the key. That's how it usually works. So thank you so much for your presentation, of course, and answering all the questions. And as always, remember that if there are any other questions that you have and you wish to get some sort of more information on your personal case, you can get in touch with GYNEM Clinic and the team. You can see the email right here. I'm sure they will be able and happy to help you out. And remember, we will be back with some more events with Dr. Kristýna herself, but there are some more events with other doctors and other clinics from different countries. So we are here to support you and answer as many questions as possible. So thank you for your time, Dr. Kristýna, and thank you everyone for joining us today. Lovely to have you back. Looking forward to some more events. Surely during the year we will see each other a few times more, I'm sure. Thank you so much. And remember, it has been recorded. It will be available, so you will be able to rewatch this. It will be available on our website, myivfenses.com, and our YouTube channel tomorrow. You can subscribe. That way you will be notified when the video is uploaded. And yeah, have a lovely evening, and I hope to see you back here quite soon. Dr. Kristýna, thank you.
Okay, thanks
Everyone
a lot.
else, thank you so much.
Lovely evening to everyone, and see you soon.
See you soon.
Bye-bye.
Take care. Bye.
Bye-bye.